This video has been funded by an educational grant from Biocon Biologics Limited. The European Alliance of Associations for Rheumatology, or EULAR 2025 Congress was held in Barcelona, Spain, on June 11th to 14th, 2025. Rheumatologists, other health professionals, individuals with RMDs and industry partners came together to discuss key challenges and emerging opportunities in the field. Professor Jürgen Rech, consultant at Friedrich Alexander University, Erlangen-Nuremberg, was among those presenting among a total of 177 sessions and 1,505 posters. We opened with a discussion about his presentation to the Congress in a debate session on treatment choice for high-risk patients and which criteria determine risk profile.
People have ACPA positivity, which could be measured in the blood. They complain about pain for a while. And what we did years ago, we started a trial where we also include magnetic resonance tomography to see that they definitely have inflammation in the dominant hand. Because in our opinion, this could enrich the population of people who definitely will get the overt rheumatoid arthritis disease in between 1 year. And so this could be the window of opportunity to treat them, to prolong the onset of RA, or even to avoid the onset. This was our hypothesis there. These patients wouldn't be treated at all. You can measure the ACPAs, which means not really something. We know that these antibodies will be in the blood measurable up to 10 years before the onset of the disease. But these patients do have arthralgia, and the life quality of these patients is also reduced, nearly in the same way if they have had the rheumatoid arthritis overt. So it's pretty interesting that these peoples will definitely go mostly into an RA. And so, in our opinion, it's necessary to treat them.
What is the treatment sequence from then onwards?
We treated these patients for 6 months with abatacept, stopped the treatment, and we're following them for another 12 months. There we have seen that we could delay the disease onset. Interestingly, and this is also now presented here at EULAR by my colleague, Koray Tassila, he will show that we can prolong or delay the onset up to 5 years with just a treatment of 6 months. And Andy Cope, who did nearly the same study, he treated the patients for 12 months. He could also delay the onset also up to 5 years. So the onset will be definitely later. And with that, we can spare costs, I think. Because on the other hand, actually there's a big project from Horizon for big teams started to discuss and to get an idea about difficult to treat RA. Because these patients failed regular therapy up to 2 different types of mode of actions, like biologicals or TS-DMARDs. And this costs annually 55 billion euros a year because they failed all these treatments. So it's pretty late for them. We have joint problems in these patients, and interestingly also life quality is maximum reduced. So you can see if you treat late, what will happen and how the costs are. So in my opinion, but I'm not an economist, I think to treat them earlier for 6 months to delay a disease could help to spare money and save life quality.
Is there an economic need for a new or repurposed biosimilar in this instance?
Of course, because it's clear that a biosimilar is always cheaper. Actually, the problem is that there seems not to be any biosimilar for abatacept. at the moment. So that's the problem, I think. But overall, we have to find the right treatment for these patients who will do the same things to delay the disease onset. And we have to get much better imaging modalities included in these things to enrich these patients who are really at a high risk for developing RA.
What do you expect your opponent in the debate session to raise in their presentation?
Yes, of course. I think they will highlight the costs. That is not recommended by EULAR and ACR, actually. So that it would be not possible to treat these patients. But I think we are not always doing what EULAR or ACR recommend, because this always happens later on. Because first we need the data to get able to recommend something. So we have do the science first, and then to show that it is safe, effective, and that we can save costs and increase the quality of life of the patients. Then it's fine, I think.
What other presentations are you looking forward to at this year's conference?
There are some new things about autoinflammation, which means for me Still's disease or Behçet's disease or Wechsler syndrome, which is definitely of interest for me. I want to follow that. And also to see hot topics like how we treat PSA, actually, what can be improved, or rheumatoid arthritis and so on. So that's could be an excellent choice to see new opinions, new medications. I hope to see that.
How has the COVID-19 pandemic influenced conference content and patient care?
We still have the problem with long COVID, actually. We know that 10% of patients suffering from COVID can get or will get an autoimmune disease, which is new. These patients have the signs and symptoms as we are familiar in autoimmune diseases, but they didn't get recognized. So they were always put into the box of psycho patients. And that's pretty difficult, I think. We should look with the right imaging, with the right things into these patients to depict as early as possible the transfer to an autoimmune disease, and then to treat them accordingly. And what we know from the old, the old autoimmune diseases. Actually, we are working in Erlangen also on autoantibodies that can be depicted on some or of the cohort of long COVID patients. So this could be a new definition of autoimmune disease, in my opinion. We can treat them, for instance, actually by immunoadsorption to reduce the antibody levels. Or we have a new drug which can help us in the near future, I hope. It's an Aptamer, it's BC007, and this is quite interesting. And what we also see here is that it is not only long COVID, there are different cohorts of long COVID patients who present with different symptoms, like postural tachycardia syndrome, for instance. Not only fatigue, but also fatigue is sometimes included or mostly included. So we should look carefully on these patients, and we try to do a better job than we do right now, I think.
What areas of future research are of special interest to you?
Absolutely. I think we will do a better job in difficult to treat RA, because we now have the T-cell engagers. We have the CAR T-cell therapy, which are doing an amazing job. For instance, first CAR T-cell in lupus, but we can perhaps transfer that for other autoimmune diseases. T-cell engagers have done a great job in a small cohort run by my colleague Ricardo Gris-Abouillet on difficult to treat RA patients, and there's a large going on in this area. So I think, and I hope that we can solve some of the autoimmune diseases, for instance, or even prolong the remission time in these patients to give the patients regular life with good quality.
How much does the financial toxicity of novel treatments complicate the use of T-cell therapies?
It's always the problem that we count the actual cost of a treatment, but we do not see what will be the costs in the future for these patients. Looking on the difficult to treat population of RA patients, there we can see that 55 billion euros annually will cost to treat these patients for the whole situation. And if we can avoid that these patients get into this process of difficult to treat, that will definitely reduce the costs in these patients. So we will, at the end, we can spare money, I think, and this should be possible. Although it will cost at the moment a high amount, sure, definitely. To get the information, and actually this works quite fine, I think. We should do that. And I always ask the people then, what would you prefer? Being treated as an RA at risk patients or get in the situation of difficult to treat RA? I think the answer is quite clear.